Hello, thank you for that introduction, and thank you for involving me in this conference. What I've heard so far in terms of the treatments from the patient perspective are important. So as I am ending this conference, I want to actually give you perspectives on early detection. And really for gastroenterologists, that's what we're really geared for, is to try to actually prevent it so you don't have to see the oncologist or the surgeon, or at least to change it so that the patient can have the best possible treatment from an early diagnosis. So what I want to cover today is three things. One is what are the current programs that are available in Canada and the guidelines? Because I think before we talk about early detection, you need to understand what's as a country. Next, and probably most important, is the evolving screening evidence. And certainly, as you've heard, we've all seen the trends towards earlier cancers. What's the evidence and what are the guidelines asking us to think about? And then lastly, I think for the audience, just to think about perspectives, whether you're the public or a physician or a health you actually modify the screening guidelines and what can we do. And in the context of this talk, I want to use the phrase early for early detection as in earlier cancers and possibly at an earlier age. So starting with programs, and I always start with this slide from our own Alberta program. And a number of years ago, we were promoting colon cancer, as we annually do through a number of tweets. But just to remind people that colon cancer is one of the most preventable cancers of all those that are out there. And the majority of patients don't have any symptoms until it's too late. And so working at the Cross Cancer Institute over cancer centers, it's still astounding to me that the most common comments that I get still is that people are astounded that they're there because they said we had no symptoms, we had no idea. And so the idea of looking for early disease before symptoms is really paramount in terms of how we structure our screening and actually how we prevent more serious colon cancer. In terms of clarifying terminology, we're talking about colon cancer, bowel cancer. Rectal cancer is, again, a little bit different, like Dr. Gill said, but it's close in terms of what we're talking about, but not to mix up that this isn't stomach cancer or anal cancer. While those two are important, there are different algorithms and different causes and prevention. So one of the reasons that colon cancer is so preventable is that it does go through these stages. And as a gastroenterologist, I see every one of these stages through in clinic or through the endoscope. So for example, at stage 0, which is really essentially a polyp, and a polyp, which is called an adenoma, by definition has low-grade dysplasia in it. And we know that as it evolves, turns into high-grade dysplasia and likely a cancer, that's when it's stage 1. And it grows from the inner lining, and as it advances and up to stage 2, it starts to hit through the muscle, touches the muscle wall. By stage 3, it's evolving through the lymph nodes, and then by stage 4, unfortunately, it's gone outside to different. Traditionally we've talked for years, and Dr. Gill has probably updated us that they're much better now in terms of survival. But the main thing about screening is that we're trying to do something called stage shifting. So we're trying to diagnose cancers at an earlier stage. And as you can imagine, the earlier that we can actually diagnose, the better chance there is. It's really important compared to many other cancers in screening is that if we resect polyps at that stage 0, that dysplastic stage, cancer will never form. And so that's one of the things that, as we're talking about screening programs, we're actually in the cancer prevention business as well. So this is a slide that actually I show my medical students as I'm teaching them, and just to show you that from the normal colon or the normal tissue, and as it evolves to carcinoma, there's many steps that have to happen. We call them either tumor suppressors have to be turned off, or proto-oncogenes or genes that actually promote cancer need to be turned on. All of these things typically take time. And in the normal person, what's called an adenoma or polyp, it's at minimum 5 years. And from that adenoma to a cancer, again, it's another minimum of 5 years. And this frames a lot of our screening discussions. And that's why in most normal people, the interval, from a normal colonoscopy may be 10 years. Now, we know that for younger people will be accelerated. But the important thing is that if we interrupt the cycle, if we remove the polyp before it turns to the cancer, you essentially are actually helping to exacerbate. So with that being said, now understanding kind of the basic premises for screening and trying to stage shift, how effective are our colon cancer screening programs in Canada? So back in 2006, 2007, when we were starting the initial pitch to our health authority about starting a Northern Alberta Edmonton Zone screening program as part of our provincial program, we were going through the literature, and I kind of gave them this initial scorecard. And I'm certainly not picking on any provinces, but we, in general, as a country, were doing very poorly. And these were the percentage of people in the age group that should have been screened that were screened. And so even just to pick on Alberta, we were doing a poor job at only screening 10 to 15% of the eligible population. And so this was backed by a lot of evidence. And even back then, if you look at the slides on the left showing colon cancer screening based on age and the percentage of the group that was screened, whether it be Canada, Atlantic Canada, Saskatchewan, or BC, if you look at the red line, which is 50, almost all those lines are below 20%. And so we were not getting the message out to screen early or starting at age 50. And for most of those, curves were starting to bump up later as the years moved on. We were still roughly, not screening a majority of people. So the orange bar there represents Canada, showing that whether you get a poop test, which was the fecal occult blood test, sigmoidoscopy or colonoscopy, only 40% of those that were eligible were getting screened. Now, moving ahead, we're starting to see some change. And in 2012, which is the yellow bars, we're finally starting to see a difference. And so in 2012, we were starting to approach 50% in most provinces. And by the time we hit the yellow bars, we're above 60% and almost 70% in provinces such as Manitoba and Ontario. And this is the most recent data from CPAC on the site from, again, health surveys showing that most provinces are getting close to that 70% mark. Alberta itself, again, we started at 15% and we're up to almost 69% of the target population being screened. So we've made huge strides in 15 years. And so the obvious question is, how did we get there and how did we improve the screening rates? And using these, can we use this as a plan for improving screening in the earlier population? So I think the number of two main important points that I think that's happened over this time is to one, to recognize that this is screening, and screening is looking for disease before symptoms. And again, as a gastroenterologist, the most important thing I emphasize to people is get screened. That's when we actually find early disease. That's when we actually find polyps that can be removed, so that you don't have to talk to the surgeon and don't have to be referred to the cancer center. The other I'm going to talk about this is the formation of organized or programmatic screening throughout the country. So opportunistic screening, which is what had happened for decades and years before, was the current standard. And while I'm a big promoter of having people seeing primary care, I think using primary care as the entry point for all screening is probably inefficient. And the reason for this is that these are case-by-case basis. You need to have someone, whether the patient or the client or the primary care provider, initiate a talk about screening. Often a patient or a client will see their primary care provider because they have a symptom, and often the screening discussions get pointed or pushed to the end of the discussion, and then sometimes there's not enough time for it. Because these are one-on-one, there's no standardization. And obviously, looking at populations that screen, you're actually biasing towards people that actually have. We need to think of something broader so that all of the population, once they hit the target ages, can be eligible. And I think as we move to the younger populations, which may not even have a family doc yet, this is something really important to keep in mind. So in 2019, when we did a survey across all of the country, I'm very happy to present this very blue map. And what is like for all the provinces and territories that actually have programmatic screening. They have provincial screening programs, and the ones in darker blue are the ones where it's very close, it's planned or announced. And I can tell you that when we started in 2005, this grid was essentially all gray. There was no organized screening programs. And if you look at the details of these programs, many of them were started in the mid-2000s. Some of them have just been initiated, so we're very happy that Yukon came on in 2017. But all of these are linked to provincial authorities, linked to governments, and partly when we meet as through CPAC, we're a mix of our screening programs, of governments, of patient support groups, and so all these provincial programs. The one thing about the program to show you is that they are similar, not identical, but similar in terms of what they recommend. And so right now in every province, the starting age for average risk screening, so someone without symptoms or any strong family history, is to start screening at the age of 50. And in most cases, the interval is to have regular screening every 1 to 2 years. And in most cases with what is called the FIT test, or the fecal immunochemical test. Now, this FIT test was a significant game changer, and I'm going to show you some slides later on showing how much it actually bumped up screening throughout the country. In most provinces as well, the stop age is around 74 to 75. So do we have a unified set of screening guidelines? And the answer is no, it's close. And this is from the Canadian Task Force. And what the Canadian Task Force for Preventive Health recommended is that screening should be between the ages of 50 to 74, and 50 to 74 inclusive in that. And that the primary test should be this FIT test, or this FIT or a flexible sigmoidoscopy. What you see and what may be missing is you may be asking, where's colonoscopy? And I think it's going to be really important to point out that for primary screening for the average risk person, we actually don't recommend a colonoscopy. And again, I'm going to get through some slides to talk about why. But through this, it actually feeds into what looks like a very complex algorithm. But what this shows you and what it emphasizes is that screening, even though we think it's relatively easy, when you have multiple initial tests like the FIT test, you have multiple risk factors from the patient, either the average risk or they have family history, and then you need follow-up, and then you need this repeated. It does end up being quite a cycle. Programs are really geared to actually tailor and actually help the public to understand this. The other part too certainly is actually helping primary care providers help their patients to go through these pathways effectively. Now, these are the national recommendations and guidelines, but to let you know, the real power, because every province can have their own set of guidelines. So for example, in Alberta, I helped write our guidelines in 2013. It was a major review. There were guidelines before, but this was a major shift as we were implementing the FIT test in 2013. And so at that time, we had a number of stakeholders, important groups come together to set these guidelines. And just to show you the vision in 2019, again, a very complex looking set of algorithms, but really follows the same type of path. That we're screening people 50 to 74. We're using the FIT test as a primary entry tool, and then figuring out ways of what to do if the test was positive or negative, how do people cycle back in. And so every province and their screening programs has a similar type of sets of pathways. So obviously the question to ask, and certainly if you're thinking about how to change guidelines and how to change and influences, which guidelines do we choose and how do we do it? And is there one set of guidelines that kind of rules all? And so this is a slide I took when I was making my initial pitch back in 2012. And I said, these are the guidelines that I'm currently looking at. I'm looking at CAG, which is the Canadian Association of Gastroenterology. I was looking at our AMA, which is the Alberta Medical Association guidelines. The ACP, or the American College, which helped publish the U.S. Presenters Services Task Force guidelines. ACG, which is the American College of GI, which is an implement internationally, the BSG, which is the British Society. So just to show you that when we're actually making these guidelines, we're actually looking at the entire gamut of the evidence that's available and trying to pick the best well-suited set of guidelines to fit our province. And there's many differences. We have slightly different populations. We have levels of being able to screen with endoscopy. So that's why province to province there is little and some small differences. So that is the current set of guidelines and the programs that we have. So what about the evolving cancer screening guidelines? And so within the last 10 years, we've followed the incidence rates of cancer. And as you can see, we're able to look from each major zone. And the bars on the right show kind of the aggregate for Alberta. But the good news is that between 2011 and up to 2016, when this data was published, is that there is an overall decline in the incidence of colon cancer per 100,000 people. And certainly it's a reflection of our screening programs. It may also just be biology, but we're certainly happy to see that. At the same time, we're following ages and looking at what the peak ages are and when things are starting. And so these are age-specific incidence rates for men and women, males in blue, women in the orange bar. Incidence is when we detect the cancer, and certain mortality is death. But what we started to look at a trend and seeing is that takeoff line, so where the line goes from flat and starts to rise up, certainly it's evident at 50, but you can even see from the incidence bar that it's starting to go up at about 40 to 45. And so that's something that actually kind of raised our concerns, and we knew we had to look at that. So then in 2018, I think one of the most major guidelines that came out was from the American Cancer Society. And they published an initial set of recommendations from their standpoint, from the EAOCC, that said that we really need to look at changing the starting age. And the reason that they did this was from a number of models. They did have some real life evidence, but it was based on a model. What I'm seeing again in Canada is that overall, in the 50 plus age group, which is the top graph here, from 1975 to 2014 when they did the modeling, there's been a substantial drop in the incidence per 100,000 people of colon cancer in men and women. So for example, in men, it was close to 250 per 100,000 in 1975, and it was below 150 in 2014, so a significant drop. That being said, in the age 20 to 49 group, we actually see a little bit of a different trend. So in 1975, we're roughly seeing 10 per 100,000, and that was slowly increasing over time. And so it's always concerning when one group doesn't follow the trend. This is what raised the alarm. Now, when we looked at this, if you look at the absolute change in numbers, we initially said that from men at 10 per in 1975 per 100,000 up to approximately 13 per 100,000. That was 3 people per 100,000 that were changing, so not dramatic. However, what it really underlies is that things are changing, or it's really declining in incidence. In Alberta, we actually had a chance to look at some of our own numbers. And the reason why is that when we were actually doing our fit testing, we actually have very good data looking at different age groups, how many tests were done, how many of them were positive, and eventually trying to follow up what happened to them. And so we were one of the few provinces that actually had a screening age group starting at age 40. And it was not for everybody. We actually set a cap on it. It was for people with a family history, but those people with family history were older. And so we wanted to recognize that having colon cancer in your family is a risk, but it's certainly not the same having a father who had colon cancer at 89 versus having a father with colon cancer at the age 45. And so this age 40 to 49 age group was for those with first degree family members that were older. And if you follow the blue arrow across, you can see that age 40 to 49, that in 2020, we registered about 7,500 fit testing done in this group. And if you follow the green arrow across the rows, you see, so how many fit tests were actually positive in this age group was 7.5%. And what was actually interesting to me is that this is actually not that far off the target age group of age 50 to 74, where the percentage was 8.3. So if you're having the positivity rate being similar, which means these are people that need to go on to the next step, which is colonoscopy, these numbers aren't too far off. So our research group, we collaborated with primary care investigators as well. So Mike Colburn and Paul Fritsch are both in the Department of Family Medicine, and they're both academics as well. And we looked at multiple data across the U.S. Alberta data, actually Dr. Brenner's data, which is here from before. And we also confirmed what the ACS had saw was that the overall absolute increase was about 1 to 4 per 100,000. And at that time, when we initially published the study, looked at it, we said, the numbers are going up. We should be looking at this, but right now, should we be changing the guidelines yet? We said, well, maybe not yet. Because that being said, we knew the trend was coming, and we knew that this was going to be discussed. And so what was the real game changer for evolving evidence was that the U.S. Preventive Service Task Force just published this year the new set of guidelines. And in their new set of guidelines, they very strongly looked at the younger age group as well. So in terms of breaking down the recommendations, this is what they said. They still said that our main focus for screening needs to be between ages of 50 to 75. This is where we pick up the most cancers. This is where you actually, if you put them your dollars, you might get the most value for it. You'll pick up the most early cancers. And the age 50 to 59 is you're seeing 48 cancers per 100,000 people. The big change, though, is that they really looked at some modeling and looked at that age 45 to 49 age group range, and they've actually now changed. They've actually said that this is what we call a grade B recommendation, which means that this will have moderate benefits, and we probably should be screening this group. And so they do recommend that we do start screening at the age of 45. And the reason it's moderate is that looking at this age group, and the numbers don't quite align, but when looking at absolute risk from age 40 to 49, that they're seeing that 20 people per 100,000 are getting cancer. So certainly not as high as the 50 to 59 group, but it is starting to move up. And lastly, what about the elderly population? So it's interesting that over age 76, the recommendations, and this is across the world, is that we shouldn't do regular screening. We need to tailor it to the person. And I often make the example that if someone just had a heart attack and they still have a major comorbidity from either stroke or heart disease, it probably doesn't make sense to be regularly screening them and putting them at risk. However, you've got an 85-year-old that runs marathons, absolutely them screening. So the other important group that actually published on this year, and important because I said this is our professional gastroenterology groups, is the American College of Gastroenterology. And the reason why this is important is that looking at different professional societies, when they make recommendations, it really follows what the rest of us do in terms of practice and even a screening programs what we'll consider. And one of the prominent ones on this committee was actually Linda Rabinick, who's actually from Ontario, who's a vice president of Cancer Care Ontario. And so she was prominent also helping these recommendations. And similar to the ACS, they looked at this age 40 to 49 age group, and now they're actually giving a conditional recommendation that we should start to do it. The reason all of us are a little bit hesitant still and not jumping right on is that the overall level of evidence is low. We're seeing the trends going up, but we really still don't know what the overall benefit of screening here. And there are some potential downsides, which I'm going to go through. So that's the current evolving guidelines. We know that there's a trend towards younger screening. There's multiple groups from everywhere from the American Cancer Society to the U.S. Preventive Services Task Force to now major GI societies. But how do we actually modify what's happening in Canada? Because if you think back to the slides I showed, the starting age is still 50 in Canada. So one of the things that I'll go through this conference is to focus on a number of things where you may be able to help those under 50 be detected earlier. So we'll talk about how to facilitate symptomatic care and get the word out. Just a quick word in family history, because I know that was talked about earlier today. How to recognize some high-risk conditions, and then to talk about some advocacy. So in the population, they do not go through this. And so a lot of times we get patients coming in and seeing a gastroenterologist, and they're seeing some blood. Some people are alarmed and they go to emergency. Some people see a little bit of blood and they just ignore it. They just think it's hemorrhoid. So the message we always have is that if it's new and it's persistent, so it just doesn't happen and then it goes away, it's there persistent and maybe is ongoing, it's really important to have an examination. This is where you need to see your primary care provider as a patient. And I always, and my students know this, we don't like to do a finger rectal exam. The patients don't like it, but honestly, sometimes that exam is life-saving because if a lump is touching, it can change their stage shifting dramatically. The other is just looking for anemia. And some patients have anemia for different reasons. They may have celiac disease, they may be vegan and not have enough iron, but it's unexplained and it's associated with things such as diarrhea, weight loss, or really new abdominal pain. That constellation of things will always catch our attention. So to make it a little bit easier, because a lot of these things can be common in Alberta, in conjunction with what we call our strategic clinical networks, which is provincial, we have multiple stakeholders, we have patient input, we've actually come forth with provincial pathways. And actually you can Google this. If you Google AHS rectal bleeding pathway, you can actually find this. What they do is to give a pathway for a primary care provider and then some patient resources to have at least a thought of when is this significant and when is this not. And so I'm not going to go through this whole pathway, but just to shows you that as you initially go through these initial boxes, it actually provides some guidance of actually how to investigate and when to eventually refer the patient. So this one is for rectal bleeding. This next one's for anemia. And so again, I was involved provincially in our guidelines for establishing anemia, and it led to this actually really practical pathway. So again, not all patients with anemia are worried about cancer, but certainly there's certain ones that are. And so if you go through the boxes, who actually is anemic enough, who actually these are ones that eventually will lead to a referral to our gastroenterologist. So I know, again, this was talked about earlier, but family history, and just from a gastroenterologist point of view too, is absolutely essential. And in fact, almost all the screening guidelines start at this point, is that if you have a family history, you're the important question is not just, did you have a polyp or was it cancer? What was it in a first degree family member, and were they really advanced polyps? And again, as a public, and sometimes even for primary care, they may not know what are advanced polyps, but we certainly have guidelines for that to show what it is. And certainly if there's multiple first degree members, that family may be. There may be other things as well. For example, a young woman that has uterine cancer may actually hold a syndrome called Lynch syndrome. So actually, one of the patients I saw earlier today, we just did her surveillance colonoscopy. She had 4 siblings with colon cancer. Her father had colon cancer under the age of 50. Her daughter is also my patient. We're starting screening at age 25. She herself did not have colon cancer. She is actually, for her, part of this Lynch syndrome. And so extremely important to talk about family history. What about high-risk conditions? So certainly people with a personal history of colon cancer and polyps need to be followed, and they need to have recommendations. But certainly inflammatory bowel disease increases this risk, and those people with genetic syndromes such as Lynch syndrome or a polyposis syndrome may be at risk for colon cancer. So I end off with a number of last 5 or 6 slides about advocacy and about changing, because I think to just changing guidelines is difficult until you really normalize the discussion about digestive health and about colon cancer and screening. And so I just show here a slide. So I know this is Chadwick Boseman at the age of 43, and here's an article in the Globe and Mail that was a few years ago. But I think these are important to get out there. It's important to discuss with people that it does happen among younger people. It happens among everybody, whether you think they're feeling healthy or not. And to get this out among friends, family, the general public, forums like this, and with government, because that's the only way that we're going to actually increase screening resources. So here's some other advocacy things that I get asked commonly. So, why can't we just start screening at 40? Why don't we just do it now and just get it done? I get asked by this for the surgeons and my colleagues. Why should we start with FIT screening? So again, as I told you from the Canadian Task Force, we actually don't recommend starting with colonoscopy. We recommend starting with FIT screening. And the same thing, why can't we just fund a colonoscopy for everybody? So in terms of when you're making these advocacies and you're asking for things, it's important to ask for the right types of resources. And this was a really important paper that came a number of years ago to show you that if we start at age 45, we do think it's going to have really older cancers, but it will potentially have some unintended consequences that need to be balanced out. And so one of the things that we often said is that if you're concentrating on this younger age group, and remember, they have less cancers per 100,000 than the normal population, are we taking away some of the attention and some of the resources from those that are over 65 or older? And so if we did this, we have to be very clear to make sure that the entire spectrum of people that are at risk of colon cancer have equal weighting and actually resources to encourage them to screen. The other part about this is that if we do this, we will undoubtedly increase cost. And certainly you cannot have a discussion about screening without talking about costs. Governments will actually respond to this, but we actually show them the number of thousands more colonoscopies per year that this would take. This may actually change their minds. So again, having these balanced discussions and knowing that you are thinking about the entire spectrum is important. Now, here's some of the other unintended consequences. So as part of my practice, colon cancer is by far, it's a big killer and big for diagnosis, but pancreas cancer, esophageal cancers are increasing. We're seeing stomach cancers come over and liver cancers. All these require GI resources. For esophageal, stomach, and even pancreas, it takes endoscopy resources. And so every time I'm doing a colonoscopy, that may be a case that I'm taking away from something else. So even throughout my list that I'm looking at day to day and month to month, I'm trying to balance risk among my patients of getting those that are most needed to see me. And while I'm be very happy to be able to do a colonoscopy for everyone, I know if I did that, I would actually take away resources from patients that potentially have other cancers. You advocate, what I would really push for, what all the provinces that follow now is really a push towards FIT screening. And FIT screening is powerful, and just to show you that In Alberta, when we turned on FIT screening for 2013 and 2014, we almost jumped almost close to 80,000, the number of people tested per year. And that number, even through the pandemic, has continued to rise. So we're doing approximately 250,000 screening tests per year. There's no way that we could do 250,000 colonoscopies per year in Alberta. The other thing is that when we do this, and this is a grid of Alberta, we can actually tell what are hot spots and cold spots for screening. So blue is good. Blue means the higher percentage of people are screened. Red or dark red are lower areas. And so it actually shows resources to increase screening in those zones. So it's either very powerful things because FIT screening is specific to colon cancer screening. If I did this for colonoscopy, it would be very difficult because colonoscopy is also used for diagnosis of other diseases, people with diarrhea or inflammatory bowel, and also for treatment, people that are bleeding or other conditions. Now, to answer the question about having colonoscopy for everybody, this was an important lesson that was taught to me a number of years ago. This was a slide that was shared to me by Graham Young. Graham was a professor of medicine. He was the head of the Australian colon cancer screening program, and he really taught a lot of the world in terms of the right ways to start a program. What he showed was that if you use the guaiac test, the FIT test, or colonoscopy, if you look at their sensitivities, by far colonoscopy is the most sensitive test, and the GFOBT, which is the guaiac test, was not that great. We think the FIT is better than 68%, but the most important thing is if you look at the right side of this table, which is cancer yield, colonoscopy, even though it's really effective, may only have the smallest yield. And the problem is that because it's a limited resource, you may only get 5 or 6% participation of the entire screening age group. However, if you use the FIT test, which is highly sensitive, and actually it's been shown in multiple studies that people are more willing to do a FIT test than the guaiac test and colonoscopy, you're going to have the highest yield. So again, you're bang lots of people seen. FIT programs across the world have been shown to be the most cost-effective in detecting the most cancers. So in terms of getting to really the bottom line, if we want to actually change it and have younger people screen, who do we need to talk to? So the power among each of the provinces does sit within the provincial screening programs. When our Alberta program is 5, that will have drastic changes through every screening unit and every small zone. Now, the partnership, CPAC, is very important, and through this was the National Colorectal Cancer Screening Network. This is an avenue for us to meet. However, these are more advisory and network groups. We compare our screening guidelines, but we don't actually issue a national screening guideline. So all the screening programs meet through CPAC and this NCCSN group, and it's good to have advocacy there. But again, the provinces influence each other, and they set their own agendas. At the other end, professional groups such as my own Canadian Association of Gastroenterology are very important because when we set forth guidelines, that does carry a lot of weight. Most of the programs have gastroenterologists like myself highly involved or if not leading these. And then other task force, set by Canada Health, such as the Canadian Task Force, are very important and influential at changing the guidelines. But that being said, the provincial screening program does not have to listen to the Canadian Association of GI and does not have to listen to the Canadian Task Force. They will make their own decisions. So the last thing is not to certainly minimize it, but groups like CCRAN and the Canadian Cancer Society and even our own Canadian Digestive Health Foundation through our CAG are really important because one of my first slides I said was about normalizing the discussion. And I think, if you, think back a number of years, it's prominent because people were willing to talk about it. The change later about colon cancer screening was always a bit hush-hush, and I think over the last few years, it really has started to change where people can talk about it. But any avenue that you can bring this up with the public, to have people, talk about and normalize discussions about screening. I have so many people that still will say, I will never, it still astounds me. But again, I'm not in the right reference point. Now, this is where the public needs to talk to each other about demystifying fears and actually changing hesitancy. I think this is where we can really make the most difference. So just as a summary, just in terms of advocacy, I think, it's easy for me to say we should just change the guidelines with a number of things. We need to normalize the concept of digestive health and colon cancer screening so that we can start to talk about at an earlier age. We need to talk about among our family and our looking at personal history to recognize the risk. We need to support programmatic screening. And while I do know there's many private screening centers is a public health approach. None of us would actually think that getting vaccinations by yourself would be effective. It's best done through large models and through public health. And then lastly, to understand that these digestive health foundations, these provincial screening programs are really the ones that we have to talk to, and they're the ones that are considering changing screening in our provinces. So with that, hopefully, this has been a very quick 35 minutes, but hopefully I've given you a good overview about colon cancer screening fundamentals and why screening early is the best chance for prevention, how evidence is evolving and what we're looking at from our current standards to what's coming up in terms of guidelines and lastly, advocacy. And again, normalizing these discussions and actually talking to the right people with the right balance to actually get your message heard. And with that, I'll end, and thank you very much for attending.
Dr. Wong, thank you so much. I think you probably practiced speed talking a little bit just to move through such fine information in such a short period of time. The key recurring theme throughout the day very much has been early detection, early detection, early detection. Do you actually see earlier detection for colorectal, early age colorectal cancer in our immediate future?
I do think so. I think the programs are meeting. I think when you have the U.S. Society Preventive Task Force talk about it, and actually, I know all of our screening programs are starting to look at it, that there may be meaningful change. But again, if we change the age to 45 and we don't have the population taking that up, government's going to notice that. I think this is really a collaborative effort. We will do our part, but we also need the public and messaging to go out that this is the right thing to do.
Yeah, very much. And that certainly starts with an increased awareness period of the issues related to early onset colorectal cancer. It's not an old person's disease. I think there's a lot of steps that need to be taken. Thank you so much for a very fine presentation.